All right, welcome back again to Basically EMS, which I believe is your favorite EMS podcast, right?
Yeah,
I think that's what you told
pretty
me
close.
on camera.
I mean, it's like in your top 5, right?
Yeah, for sure. I mean, maybe 9, but like top something.
Yeah,
for
it's
sure.
a number.
Cool. Today we are going to be talking about burns. So I think we got some pretty good notes. I think we're going to go a little bit into depth in burns.
Yeah.
So really important thing for us to talk about. We're talking about it earlier. Not a super prevalent call type that we tend to go on, but they can be pretty gnarly and life-threatening. So, cool. Let's just jump on into it. So, burns. There's a whole different gamut of types of burns that we'll jump into later, but just kind of the kind of general information about burns, right? So. Burns are going to be from all different sources. Typically, it's going to be when the skin is opposed to temperatures higher than 111. At least that's for thermal burns, right? So thermal burns, it's usually going to be temperature 100 or 111 or above, something like that. The amount of time is really an important factor when we're talking about burns, too,
Same
right?
with age. Age is a big factor.
Age is a big factor just based off of the thickness of the skin, right? Really little ones, really old ones, that thin skin really can be affected more significantly with burns. Duration, like we've all been out in the sun for 20 minutes with no issues and 10 hours with no sunscreen, you're going to get pretty significantly burned from radiation burn. So we need to be thinking about that as well. That can have a big effect on people. So I don't feel like we need to talk too much about burns. Are pretty well known, pretty ubiquitous of what a burn is and how it happens. And people have generally all had burns in the past.
Right.
We need to really be thinking about the skin and what the skin actually does when we're considering burns. And the skin is going to be essentially a barrier between the patient or the person and the outside world.
Right. Which just generally, if you think about the skin's whole job is to be a well-isolating barrier.
Yeah, and so we need to be thinking about what happens if that barrier is destroyed in a burn, what happens secondarily to that, and that's what the complications, most of the complications for burns are going to be due to that. So some of the complications we can see is going to be infection, obviously, if that damaged skin becomes infected from whatever around us, so we need to be aware of that.
Right. Hypovolemia is another big one.
Yeah, hypovolemia, which I have some notes about why a little bit later that we can get into, but hypovolemia obviously has a very big concern, and then hypothermia as well, which is really counterintuitive, I think, to people that like you just, fell into a fire and now you're going to get hypothermic. It doesn't make sense to some people when you think about the fact that your skin is your body's big blanket that's wrapping you.
Right.
It's your body's Snuggie.
Yeah.
You know what I mean? Just sitting on the couch watching TV in your skin Snuggie.
Your flesh Snuggie.
And so if some of that gets destroyed, temperature regulation is gone. We're not going to be able to hold heat in anymore or hold a body temperature in anymore.
Right. It's the same thing as like if the insulation in your house gets removed, your house is going to get really cold and really hot.
Yeah, and I wouldn't even say, kind of insulation, but that's also taking like the outside wall out as well, right? Like,
all layers.
Depending on the layers, how deep the burn goes, it could just be, the fascia of your house or your siding or whatever is removed, and then you could, as it goes deeper, then you're losing insulation, and it could be pretty significant. So, something for us to be thinking about. And then one of the other big complications secondary to that hypovolemia is going to be shock too, which we don't. Again, I don't think people think about that until you really think about the pathophys of burns and how it all works. But shock is a very prevalent thing we can see with significant burns.
Right.
So a couple different types of burns, talking about the pathophysiology that are essentially bad are going to be circumferential burns. And that would be kind of anywhere that you have a circumferential burn is going to be really significant.
Right. Circumferential wrapping around for those who are unfamiliar with the term.
Yeah. So whether that be like a limb, like somebody put their foot into hot water or their arm into hot water. It could be around, especially bad if it's around the chest, maybe.
Right, around the torso.
Affect that chest expansion. So that's something we need to really be thinking about with burns is where those are, and circumferential specifically, what's that going to affect circumferential around like, the arms or something is not a short-term big concern.
Could still be damage to limb though, risk to limb.
Oh, 100%. But
life-threatening.
Life-threatening in a short span of time for us, probably not so much.
Right.
Whereas around the chest or the torso, a circumferential burn can be very life-threatening because it affects the ability to expand and breathe. Right. So
just builds on that hypoperfusion.
Yeah, we really need to be aware of those things. So, and then one big thing at the BLS level too is to know how important ALS can be for burn patients because of the hypovolemia and everything. Paramedics will have the Parkland burn formula that we're going to work off or something to dump a lot of fluid generally into these patients. And then burns are just really painful.
Right. Depending on the burn, which we'll talk about.
Yeah, but even like a really severe burn that burns off the nerve endings, you probably still have that surrounding tissue that
You're
has
going to have that layered breakaway there.
Yeah,
that makes sense.
Exactly. So, I mean, in general, burns are going to be incredibly painful for people. So ALS backup's really good for that too.
Yeah, absolutely. Another thing, I know this is a basic EMT type podcast, but if you think about even from the medic or ALS perspective, getting lines on these people, getting an IV can be really difficult depending on where it is. I've heard of people doing IOs in conscious people just because of burn severity.
Yeah, because they're where are you going to go sometimes, right? If there's both arms are burned or the limbs are all burned. Yeah, I've heard the same. I haven't had to do it personally, but I have heard the same of people going IO just because the extremities are so damaged they can't really get an IV. So maybe not specifically for this podcast audience, but it is an important consideration.
Right. And it could be, from a basic perspective, if you can see that your patient has those circumferential limb burns, or because you don't need to know what necessarily you're looking for vein-wise, but it always helps when your basic is like, hey, by the way, this one looks pretty good, or that arm looks pretty good. Like if you're waiting on ALS to show up, kind of, well, you got that time to wait. Let's see what we can maybe help prep mindset-wise, and then see if we can, how the basic can help guide the medic a little bit of like, hey, you're going to need to move quicker, slower, whatever.
Yeah. Give them kind of an idea of what they're getting into. So burn severity. There's some things that are going to have a big impact on how severe the burn is or how severe we consider the burn, right? So the depth of the burn is going to be really important. And so when we're talking about burn severity, we have kind of a ranking system, right? And so there's going to be, and depending on kind of what you read that's kind of interchangeable, that we'll have like first degree burns or superficial burns. Right. And then second degree burns are partial thickness burns. And then third degree is going to be full thickness burns, right? And so that's just based off of the different layers of the skin, like, epidermis, and then working its way down as the severity gets worse. Yeah. And you can have, some burn types are going to be more like a sunburn or radiation burn from the sun is more likely going to be a superficial kind of a burn. Right. But they can get worse where there's other types of burns that are more prone to going deeper into the tissue, like a thermal burn from a fire or something like that. Right. Even electrical burns. Electrical burns are a good one that are going to typically be very deep. It's going to go through the body. So, that one can be really, really, really significant. So, other thing that's going to affect how severe we consider it is the size of the burn. And I think that comes up later to talk about more specifically, the different sizes and how we measure those things, rule of nines and all that. So we'll cover that. And then kind of where the burns are is going to be important. And then one thing can be really important is pre-existing medical conditions and how are they going to respond? Are they diabetic, and what's the long-term effects of that for these patients? Are they on diuretics? That kind of stuff. Like what's their normal volume? And
are they typically like hypotensive at baseline?
Yeah, that can have a big effect. And then we already talked a little bit before about the age is going to have a big effect. So when you're thinking about severity of burns, we're going to be thinking, how deep is it? How big is it? What structures are being affected? What's their medical history? And then what's their age? So,
if you consider those factors too, you can start thinking around the burn as well of like, okay, well, if this happens here, what's going to happen next? Right. And we'll talk about it when we get into the airway stuff.
So moving down, let's talk about kind of the different more into depth into the different depths of the burns.
Yeah.
Into depth in the depths. So superficial, like we said, is going to be that first degree.
Right.
So usually just going to involve just that top layer of the skin. Just that epidermis is going to be the only one. Which, by the way, your epidermis is showing, bro. Got him.
Embarrassing.
Got him. Half of what I say is just to make Sabrina frown at me because she's so disappointed in us.
That's fine.
It's okay.
You get used to it after a while.
Yeah, you're used to disappointment
Stops
from women.
Yeah.
Yeah.
I don't want to talk about it.
So yeah, it's going to be that top layer of the skin. And so by definition, these are usually painful, but you're not going to have any blistering or anything, right?
Right. Right. I mean, you can have it. This is where the exposure length comes in, right? Because I myself have had blisters from sunburns just being out and about for too long. But typically you're right. It's just going to be that superficial epidermis damage, typically just a red presentation and irritable.
Yeah. Yeah. Not comfortable. I'm sure everybody listening to this has had some sort of first degree, like really simple burn before, and say they know it sucks. It's angry. It's not fun, but definitely not life threatening.
Right.
You're going to recover from it. Your skin's going to recover just fine. It's usually not a long-term concern.
Right. Right.
Whereas like partial thickness or second degree is going to have the epidermis and then some of the dermis as well. So it's going to be definitely thicker and deeper for this kind of burn.
Go ahead.
No.
I'll say these are typically the most painful as well, because that you get to the nerve ending exposure point, so they are very aware of what's happening.
Yeah, exactly. These are going to be the most painful. The skin is usually kind of moist, and that's because of the breakdown of those cell walls and everything. And there's like a release of histamine and everything that causes the capillaries to be leaky. And so they leak plasma onto the skin itself. And that can cause blisters.
Right.
As that plasma leaks out into the interstitial space, it can go under the skin there and create blisters. So the partial thickness can also have blisters. And like you said, this is the most painful because you've just got those nerves are now just exposed essentially. So they're damaged and exposed just right there. And these are the most painful type typically.
Right. And I think it's important. We'll get into it even when we get to full thickness, third degree. But remember, this can be a spectrum, right? Like if you're touching a hot piece of metal, if you're touching it with the back of your hand, not all of your hand is touching that metal evenly. So you can have kind of an intermingling of types of burns.
Yeah, or it's also very common to have kind of like a bullseye pattern of like a center of a more significant burn that kind of works its way out less significant as it goes out. So that's also a really common pattern that we'll see for burns. And then full thickness or third degree burns, they're going to go through all the different skin layers, could be down to muscle or bones. I've heard of like a fourth degree burn, which is down to the bone itself.
Bones, yeah.
So I don't think that's a medically correct thing. I think it's just kind of how we kind of
more of the
it.
basis of observation on that one.
I think those are still technically considered full thickness burns. But this area is typically really dry and leathery, and that's because where with a second degree burn, that vasculature is leaking out into the soft tissue. With these, that vasculature is absolutely just destroyed.
Right.
So you're not going to have any plasma loss because there's not like it's the highway of the plasma is gone. So there's nothing to spill out anymore.
Right. Yeah. You've basically cut off the river, total flow, which also on this one, I keep falling into the pain realm, but counterintuitively, third degree burns are the least painful as far as the actual burn site goes, right? Because at that point, you're so deep through the skin tissue, if you're going to muscle, bone, et cetera, the nerve endings are fried.
Yeah.
They're gone. But everywhere around there, kind of like we mentioned earlier, probably going to be in that gradient zone of a second degree to a first degree. So they are going to still be extremely painful around it.
Yeah. You can't imagine somebody would get a full thickness burn and then there's no partial thickness around it, right? So, there's going to be some pain, just not at that exact site typically. Because like you said, the nerve endings are just gone. No more nerve endings.
Cooked, as the kids would say.
As the kids would say. You know all about what the kids say.
Yeah.
You're hip.
Yeah,
You're cool.
My daughter's like 3 months old now. She says so many things that I don't know.
What the kids literally say.
Yeah.
So yeah, the area is going to be kind of dry, and then this is where we might see kind of charred looking skin as well. You can see that for these burns.
Also, something that we don't touch on very often when it comes to burns, or I liken it to like when you see a zombie movie and they don't cover this, but the smells. There are going to be factors that are going to be playing in on your nose that you are not going to. I don't know that you're not ready for it, but it's going to hit you harder than you think it's going to hit, because that burned skin smell is very specific.
It could just smell like cooking meat, which is not great. You don't enjoy it.
Yeah. At least not when it's your meat.
Yeah,
that sounded weird,
but that's true. Yeah, we don't like the smell of our own cooking meat. That's fair. Moving on.
Yeah, sorry.
One specific type of burn that's not really covered here that's really significant for us is going to be airway burns. And so that mechanism that we were talking about that fluid shift and everything and swelling, that can happen in the airways as well. So that's usually our biggest concern in EMS in the short term is going to be airway protection and how those airways are doing and looking, right? So, long term, obviously it's concerning for hypovolemic shock and all that stuff, but in the short term, and by short term, I mean 3 to 5 minutes, not 15 to 20 minutes. We really need to be thinking about that airway and management of the airway. And this is, again, if you're a basic provider, we're getting in a medic there is really important because we can RSI these patients. We can put an ET tube in and help protect that airway from swelling closed. We can get kind of get ahead of it.
Right. And then on, kind of branching off of that, if you're slow on getting ALS there, they can still get like a surgical creg depending on their protocols. And so they can still establish an airway, especially if we're talking airway burns. Think about just a regular burn and how quickly it swells up. That same process, like you were saying, is happening in the throat, in the lungs, anywhere that flame, for lack of a better description, touches, you're going to have that burn kicking in. So swelling is going to happen fairly quickly. So identifying, this is why a secondary assessment is so important, right? Because we can look in the mouth. Do we see charring? Do we see any soot? Those are things that should be an indicator. Even if they're breathing fine, that's an indicator they had that temperature exposure.
Then kind of moving from there, we'll talk about a kind of assessment of the airway and a little bit what to look for airway burns. But extent of burns, like we talked about before, is important. And so there's a couple different ways that you can judge the extent of the burn. There's the rule of palms and rule of nines. So rule of palms is everybody's palm is generally about 1% of their body surface area. And so if you're visualizing, you can think about, okay, their palm's about this big, and I put a bunch of those over that burn, and that makes up about 5% of their body surface area, something like that. And then rule of nines, I don't think we're not going to jump into the specific rule of nines, especially because it changes depending on the age. But rule of nines can be important as well. It's going to break down the body into the different limbs, the torso, the head, the genitals, front and back, all that. And it's going to ascribe a certain percentage to each of those. And so if you have, a leg that is burned, you can be like, oh, that's 18% based off of the amount of the leg or whatever it is.
It seems like if you're going to try and decide, should I use rule of palms or rule of nines, let the size of the burn kind of guide you, right? Because if we're talking just, I don't know, a 3-inch circumferential around the arm, that's definitely not going to be like, well, what's this breakdown on 9%, right? Like, sometimes you're going to have to minimize that, and rule of palms is a good place to do that.
Yeah, exactly. Yeah. Rule of nines is really for very large burns, like full body burns or whole limbs.
Like Travis Barker burned all his skin off when he crashed in that airplane.
I had no idea.
Oh, it's a big one. Like
really?
70%.
Really?
Something crazy. Yeah.
Wow. That's a lot. Rule of nines, that would be a good situation for that. Rule of palms, like you were saying, for smaller burns. And then remember, too, you can break down rule of nine. So if it's this limb is 9% per rule of nines and it's only half of the limb, then that's 4.5%. So you can break it down. And, nobody's going to come out with a tape measure when you get to the hospital like, you told us it was 14% when it's actually 13.2. Right? Like this is an estimation just to have an idea of what we're dealing with.
Yeah. I just imagine the look that the medics and EMTs would give the nursing staff or whoever brought that ruler in. Be like, are we playing games right now? Is that what we're doing? There would be a pretty dumbfounded look on my face if someone did that to me.
All right. So we talked some basic stuff about burns. Let's jump into the assessment of burns, right? When we're talking about it, we really want to be thinking just the standard stuff, right? Like, how did the burn happen? Where did it come from? Severity. We're going to be looking for all that stuff, right? It's just kind of the general for burns.
It's not always obvious either. Sometimes it's super obvious. Sometimes it's not.
No. And so as you're thinking about how did this burn happen, obviously the first thing we need to be thinking about in this situation is our safety, right? So, if it's an electrical burn, is whatever electrical source burned that patient, is it still there, right? If it's a house fire, like what are we thinking about with that, or a car fire, whatever it is, we need to be thinking about our safety with the kind of the scene size up, and then possibly if we have reports of an electrical burn, is the electrical company or somebody coming to mitigate that electrical issue, right? So,
or is the person who's being burned not touching the electricity anymore, because that electric reaction with our muscles causes the spasming down, and so if they're grabbed onto something, they might stay grabbed onto something.
Yeah, so make sure that you're thinking about that. This is, especially electrical burns, are not one where we just want to like rush in because maybe they're still actively attached to that electrical source, and we don't want to just be like, hey buddy, and join them on their ride.
Sounds awful.
Doing the electric slide over there. And then so another thing to really think about with this is going to be number of patients as well, because this could be, like I was saying, car fires or that kind of thing, that we need to make sure that we are assessing the number of patients and really looking for more patients, because this tends to be or can be large scale events like fires and that stuff. So we need to be really thorough about searching for our patients and just making sure we're determining that correctly.
Right.
And then, so for the actual assessment of burns, obviously ABCs are going to be vitally important for these, and especially the airway, right? So, we generally teach basic EMTs like airway assessment. Are they breathing or are they talking to you? Cool. Their airway is good. But we need to be a little bit more in depth with these patients, right? Like, what does their voice sound like? Does it sound hoarse, like they've been breathing smoke in? That can be a very significant finding for us with airway.
And even like if the patient's talking, the airway is open for now, but then like what physical signs are we seeing on their face too that could indicate, even if they're talking and don't sound hoarse, but they have soot on their face, that still could be an indicator that we got to take a deeper look.
Yeah. So definitely look for like facial hair, see if there's any singed facial hair. Look for soot around the nose and the mouth.
Singed nose hair.
Eyebrows. Have them open their mouth up, look inside to see if there's any discoloration or anything, any burns in or around the airway. It's not unlikely that they have breathed in superheated air, and so they have some airway burns there. Right. Really be thorough about looking for that. Visually to see if you have any changes, and then listen for that voice and see if the voice sounds hoarse or if it sounds like it's changed. And then are they coughing, anything like that? Because that could be another indication, right? If there's a lot of secretions that they are coughing out, that's just the airway essentially secreting that plasma into the airway. They might be coughing that out. So be on the lookout. Be aware of coughing, that kind of thing.
Lung sounds are going to be really important as well.
Yeah, for sure. You might have some stridors from lung sounds or something as their airways are swelling.
Or crackling if they got too much plasma building in the lobes there.
Yeah. So really make sure that you're really thorough with these, at least in the situation where it would make sense, right? If somebody sat on a hot iron, like a curling iron, then we're a little bit less concerned. But if we're talking about fires that somebody's been exposed to or something like that, make sure we're really thorough about this.
Yeah. Like house fires, especially, like going back to your number of patients, that's the classic storyline of there's a house fire, the baby's still inside, right? Like you just never know. Find your patient number and then, make sure you're doing that thorough assessment, not missing anything.
And then working down to our C on the ABCs, your standard stuff here. The big thing is going to be assessing for shock and shock management. So, like we were kind of talking about earlier, what happens with a burn is the tissue's burned, and that releases essentially an immune response because of that happening. And so if you understand anaphylaxis, you'll understand kind of the mechanism that response releases mast cells and cytokines and all that stuff into that area. And so those are really harsh on the capillaries and the vasculature, the blood vessels. So the blood vessels become very permeable.
Right.
And that permeability allows fluid to leak out. And so the larger the burn, the more possibility of that fluid leakage. And so that's why we get that pretty massive swelling.
Right.
And that's why those full thickness burns can be really moist and wet. And so that massive fluid shift can lead to hypotension. And so we can have shock from burns because of hypovolemic shock where third spacing all that fluid. So we really need to be on top of looking for that and trying to manage that if we can. At the basic level, there's not much you can do.
Right.
But like we were saying at the medic level, or generally at the ILS, the advanced EMT level as well, they can do a lot of fluid boluses. Parkland burn formula is a lot of fluid.
Right.
And so they can be on that as long as they know they need to, based off of you calling for ALS or whatever it is.
Right. I mean, I say it to my students all the time. Biggest job BLS can do is recognition of the right thing and start the correct treatments. And if we're talking burns, we're talking loss of temperature as well. That's where keeping them warm is going to be a big deal, right? Like make sure you keep that ambulance warm, get blankets out and ready. And sometimes just double down on them. A little bit of both never hurts.
Yeah, I love it. I agree 100%. That's one of my biggest lines with my EMT students is like your biggest roles are recognition and resource management. That is so much because it's pretty limited for the scope, right? So obviously there's some other really important things that EMTs can do, but a lot of what they can do, at least in the medical term and medical side of things where they don't have the medications and the treatments and all that, like recognition and resource management is huge. If you can recognize what's going on quickly and get them the right resources quickly, that can make a huge difference.
Right.
So being able to recognize these things is really, really important, and being able to recognize them quickly. Like you had already mentioned too, the standard shock treatment that we teach is keep people flat, keep people warm. All right. And so that applies here as well. Keep them warm. We're going to want to do like a sterile burn dressing over it, and make sure that we're not putting it seems like the right thing to do would be like a cool compress over it, right? Because it's burn. We want to keep it wet and cool and it feels good. But that is the worst thing we can do because they don't have any thermoregulation. Right. So if we put, even if it feels warm to our hands, right? We have some sterile water in our ambulance and we pour that on a dressing and put it on top of them. It feels comfortable to our hands, but it's 75 degrees, whatever the ambient temperature is.
Still room temp. And you got to remember we're 98.6-ish normally. That's still way too cold.
Yeah. I mean, yeah, and just in general, swimming in 70-degree water, you can become hypothermic fairly quickly. So we don't want to do that to our patients that can't regulate that temperature.
Right.
So I'm sure it will come up when we talk about treatments down the line, but dry burn dressings are really important for these patients.
Yeah, I got some pro tips I'll throw in there later.
Transport decision is obviously going to be really important. There's not a lot of burn centers. I know we're here in Idaho, and there's not a burn center in Idaho. I believe Salt Lake is the closest,
that's closest.
So just know your protocols as far as where they're going to go. I know locally here, if we have significant burns, we go to the local trauma center, and they will triage and treat and then send out to the local
They're usually sent out, depending on severity, fairly quickly, too. I'd say I don't know the exact number, but if I was ballpark, it's going to be somewhere less than 2 hours. Also, I want to just touch on something real quick. You talked about our treatment of shock laying flat. If you're somebody who's out there and you're listening, you're like, well, what about Trendelenburg, where we raise the feet? Yeah, that was kind of an old practice. I don't think there's necessarily anything wrong with it, but studies are showing it doesn't really change the outcome too much. So, kind of added points if you're someone who's like, well, actually, that's what the studies are saying. Look it up.
Yeah, and that just goes to how EMS was a long time of because I have laid patients flat and put their feet up. I'm like, oh wow, I can see the heart rate come down and the blood pressure go up and everything's working. But that doesn't mean that that's what actually fixed them, right? And so now we are starting to have evidence-based medicine, which is cool. And so that is where it's pointing towards. I don't think it's even really in the book anymore. They
still mention it in a few of the slides.
Do they?
Yeah, and I give the same spiel every time. Which, once again, if you want to do that, sure. No one's going to stop you. No one's going to tell you you're wrong. It's just if you're not thinking about, oh my God, I forgot to raise the feet. Dang it. That's not the biggest thing in the world.
Yeah. Oh, I forgot to put on the masked pants.
Yeah. Yeah.
Most people listening to this probably have no idea what that is.
Yep.
But they're old, like compression pants, essentially, that we would put on patients to do the same thing, like squeeze all the blood volume into the core. But yeah, that's a very old reference.
Old, yeah.
Yeah. The mask pants, and then put them in a hair traction splint.
Oh yeah. Yeah.
Really show the age.
They're
here.
getting crazy.
So yeah, really think about where you're taking those patients, and then rapid transport can be really important. But this is a thing too where you might be thinking of like ALS intercept for airway management if you have a long transport to your hospital. So make sure that you are really thinking about your protocols and where this patient's going to go, and make sure you have that early notification is always really good for them too.
Another big thing, and I learned this on, there's no victim, but it was a house fire. Plan your ins and outs, right? If you're at a structure fire, make sure that you're not parked in a place that you can't leave with charged fire hoses around you, because that obviously is going to dictate. If we did have a victim, we were stuck, and so we would have had to call another unit, and it would have been a whole other thing. So just keep that in mind, right? Transport decision is not just based on my patient queue. It's I got to think around that. What's the easiest way in? What's the easiest way out? Am I going to get stuck or not if this goes sideways?
Yeah. Yeah, lots to think about for transport and all that stuff. And hopefully, in your situation, hopefully the whoever's in command of the scene is aware of those and putting you in the right staging position and all that.
Yeah.
Which it sounds like didn't happen that time.
Well, once they decided figured out there was no victim, there was an engine on either side. We were the first on scene for a pretty big trailer fire. And yeah, engine pulled in front of us, engine pulled behind us, rolled their hoses and charged it. And that was the moment we all looked at each other and was like, well, we aren't leaving. That's crazy. And yeah, there was no victim. We knew early on there was no victim. But yeah, it could have been really, really bad. We did get a good talking to from our soup about it, but we're the first on scene. We didn't.
What are you supposed to do?
Yeah, I don't know. Do you ever feel useless? Like, yeah, that house is on fire. Somebody should do something about that.
Yeah. And did you go up to the captain and be like, excuse me, you need to move your fire engine?
Right. Can you actually turn the water off for like just a second?
Yeah, don't drive over charged lines. That's not a good idea, too. Make sure, I feel like for burns, a lot of it is really just for your assessment is really thorough ABCs and especially thinking about the airway.
Yeah.
And then kind of from there, you're going to be doing kind of your normal stuff. So, get a good sample history, that kind of stuff on them. Secondary, like this is where we're going to be looking to try to figure out the extent of the burns and do rule 9s, rule of palms, whatever it is. Try to estimate the best you can.
Yeah. And you talked about, we need to be really heavy on airway. But another thing to consider, and we kind of talked about it, is the breathing. If we got circumferential chest burns, that's going to be something that's going to impact that as well. So remember what's inside your scope, what you can do, things like BVM, positive pressure ventilation, things like that.
Yeah, because that can kind of mitigate that issue if you're doing positive pressure ventilation.
Right.
Another thing that we don't check very often that would be really important for these patients is SpO2, obviously, but checking for carbon monoxide levels as well. So if you have a patient that, especially if they were maybe in the interior of a building or something that is burned, check those carbon monoxide levels because you might need to really be on top of oxygenation and all that for these patients because of that. So it might be kind of a secondary thing at that point for these patients, but something we need to be aware of as well.
Still a consideration that's going to make your job harder.
I feel like this side of things is pretty simple. The assessment's not super deep beyond our normal assessment.
Right. I'd say the secondary is more so just identification of percentage to the best of your ability, and then reassess 5 to 15 as needed. Likely, if it's a severe burn, it's going to be every 5 minutes, though, for an unstable.
Yeah, cool. All right. Type of burns. Let's jump into a little bit specific burns.
Fun stuff.
The most common type going to be thermal burns, and this is probably what most everybody has had at some point from something, even being a kid and touching the metal slide of the playground and getting a burn, right? So this kind of thing. So it could be open flames. Scald burns are going to be considered thermal burns as well. Right. So
steam.
Steam, hot water, those kind of things. I actually have a couple. I've only have 2 like good burn patients, and they were both like scald burns. So I think you were saying your one was a scald burn too,
I only
right?
ever really had one big true burn, and it was a scald burn as well.
Tell us about it.
Yeah, so I was in my medic clinicals, I was in medic school, and I was doing a rotation through a local ED. Kiddo came in, I want to say younger than 3, pretty young kid. And grandmother and mother were with them or with him. And so it sounds like grandma drew up a bath, wasn't checking the temperatures. And when she went to dip the kid into the water, he started screaming. So obviously that was the scald burn. And when I was there, he ended up burning most of his genitalia. His groin was pretty tore up. His buttocks was also pretty burned up. Poor kid, he was blistering pretty bad. It was one of those two because we've talked about in our course abuse, child abuse, and like dipping or like what's the word I'm looking for? Like glove-like pattern, like dip type burns is pretty indicative of abuse. This one, in my mind, wasn't raising any red flags. The doctor, I think it was more of like a cover herself type situation. She got Child Protection Services called just to be on the safe side, make sure we weren't missing anything. But yeah, and pro tip to parents out there, you can adjust the heat. If your kid's got a specific bathroom, you can actually limit the amount of hot water that comes through there, and you can make it so you physically cannot burn them. But then also if you want a really hot shower for someone not a child, that makes it tougher.
Yeah, you can change that at your water heater. You can set how hot the water heater gets.
Yeah.
So, which I know I have 2 kids too, and so ours is definitely turned down from what it was like pre-kids.
I mean, my wife takes showers that are as hot as hell. So, yeah, I offered that, and she's like, absolutely not. It's like, okay, I guess my child's skin's not that important if we think about it.
I mean, just make sure you're aware.
Yeah, we got a little duck that reads the temperature.
That's cute.
Yeah, I'll talk about it.
Yeah, I had one that talking about abuse. I don't know. Nothing was confirmed. It was a long time ago too. It was like early in my EMT career, but I have a feeling that what happened was like maybe not abuse. Abuse isn't the right word. We got on scene, and there was kind of a middle-aged guy, and he was unconscious, and he had like circumferential glove burn all the way up about to his elbow.
Yeah.
And so on the stove, there was a pot of water that looked like it had been boiling, like a big pot of water. And it just like everything was weird about it. Like it didn't make sense that he was unconscious. Not from the burn, at least, right? It would make no sense for him to be unconscious from the burn. And so there were, I want to say like his 2 sons. All I remember is they kept, whatever the guy's name was, they kept being like, so-and-so, he's a legend. He's a legend. They kept yelling and telling us he was a legend. Like, he's going to survive because he's a legend, which I was so surreal. Like, as a new EMT, I was like, what is going on? But I think probably what happened is they came in and found him unconscious from a stroke or overdose, whatever it was. And like, well, we need to wake him up. Let's get some hot water and put his hand in it to wake him up, and just burned his whole arm. So that was one of the bad burns I've been on, was like a scald burn.
Yeah.
But maybe an abuse situation. It
kind of sounds like good-hearted idiots.
Yeah.
You know?
I don't think it was like they weren't there trying to injure him.
Right.
At least like their story was that they found him like that, which I didn't believe. It just didn't make any sense that like a hot pot, like he put his arm in and then went and I don't know. That didn't make any sense to me. That was my thought, and the medics talking about it afterwards, like that was our thought that so not that they were trying to injure him, they were just trying to wake him up, and he's a legend. It was weird. And then the other one I've been on, probably one of the gnarlier calls I've been on, so a little graphic warning it was just weird. But so this was another scald, one guy that really liked, apparently, according to wife, liked to take hot showers and hot baths. He liked to take hot baths. And so we got on scene, and he had both arms, like biceps down, were just, it was like sloughing off. Like it was so bad. His skin was just sloughing off. And then he had just random spots all over. I want to say like somewhere more on the front, like so he'd fallen into the bathtub is what we think. We're pretty sure he seemed super postictal, and he had a history of seizures. Wow. So we're pretty sure what happened is he was drawing a super hot bath and had a seizure and fell in to the bath as it was drawing, and still like scalding, 140 degree hot, whatever it was. And so circumferential up both sides and then a bunch on the front. And he was just fighting us because he's postictal and he's in pain and just fighting us. And so like one of the grossest things I've ever seen, where we're transporting this guy, first and only time I've ever given pain meds without a blood pressure, because it's like, you are fighting me. I know your blood pressure is fine. You need pain meds because you are like, it was bad. So we gave him fentanyl, which calmed him down a little bit. So he stopped fighting us, but then he started like grabbing in his arms and he started biting the skin off. Like we had to hold him back. He was just and he would like strips of the scalded skin. He was like tearing them off and trying to chew them up because he's just postictal and doesn't know what's going on. Oh, it was so gross. So that one was pretty gnarly.
That's the worst chewing gum I've ever heard of, dude. That's awful.
Yeah, that one's burned in my memory for sure on that one. So that was another one that looked a little bit suspicious, but everything made sense. And just like based off the patterns and everything and how he was acting and how the family was acting, pretty sure he just unfortunately had a seizure and fell into I'm imagining he would draw a bath and let it sit for a couple minutes to get to the temperature he wanted. Didn't have that time. And
he's lucky it wasn't his face.
I know. Yeah. He got really lucky that I'm assuming he fell and kind of like trapped his chest or something
like on the
tub and kind of went in, because he did have some up on his chest that I'm assuming were like splashes as he fell in, or maybe he was seizing and that was splashing him.
Right.
But yeah, it was gnarly.
That story really highlights how important a history really is, though, right? Because that's something where it's like, why would a rational human do this? Well, if someone sees and they fell, that's a totally different story. Yeah. That's crazy.
Yeah, I don't know what it is with me, but I had it was one of the more tragic calls I've been on. Teenage girl with a history of seizures who went to go take a shower and she seized and fell and blocked the drain, and it started to fill up around her and she drowned. Like she died. We weren't able to get her back. And this guy, I have a bad history of EMS calls that involve bathtubs and showers and all that.
I've got some funny bathtub ones, but not appropriate.
not about burns.
Yeah.
Let's get back on track. So, thermal burns. It's going to be caused by heat. Can be like we're talking about scald burns from water. Steam as well is considered a thermal burn. Those can be really, really bad.
Right. Because it covers so much surface area so quickly with it being in the air.
Yeah. So just anything that's going to have that heat that's affecting the skin, right? So management of thermal burns, the big thing is to stop the burning source. That's always our big thing, is going to be to stop that burning source. So try to get them out of the environment, whatever it is, get them away from that.
Right.
And then for minor stuff, we can irrigate the burns or something to try to cool them down. And we've all done that at home, right? Like you burn your finger a little bit and you run it under the water to cool it down.
Right.
Kind of break that chain of burning.
More of like a superficial first degree type. That's where I would personally consider doing that, because if we're going to start burning, through the layers, partial thickness, temperature is still something I don't want to play with.
Yeah, no, this is strictly surface level burns. We're going to be doing that because we need to remember if your skin gets cooked at a temperature of whatever, right? Like if you know anything about barbecuing steak, right? You're not going to take it off at the temperature that you want. You're going to take it off 10 degrees before because it's going to continue to cook in its juices and everything afterwards. Right. And the same is said of humans, right? So if I have a temperature burn and I don't try to cool it down when I can, if it's a base, like a superficial burn where it's safe to do it, they're going to continue to burn and it's going to get worse. Right. And so that's why we want to take those patients and irrigate it, cool it down so that it stops the burning process.
Right. Another important one, we have it written down, and I didn't even think about it until I think about it, is jewelry. If there's somewhere hot, that metal jewelry is going to be hot. You're going to need to get that off. I will tell you, though, you will never make an enemy like an old woman whose wedding ring you cut off. Boy, they're going to hate you. But they got a finger still, so that's a win. Yeah,
and not only that, but the swelling. That's another big thing, right? Like I don't know if you've ever had to cut a ring off of a swollen hand. It can be really, really difficult. So we want to get ahead of that for sure.
Yeah. I never had to cut it off of a swollen hand. I had to cut off my own hand, but that's because I made one too small. And I was like, this will work. And it did not work.
Was this a silversmithing thing? They made one for yourself?
Yeah.
Nobody but yourself to blame.
Yeah. You feel real stupid, too, in that moment of like, look what I did to myself. My pinky's falling off.
Nice. I've had to do it once during my ER clinicals where super swollen hand with the ring. And it took me so long with the ring cutters because the swelling is so just spongy and you're like trying to get it. And then you're afraid of like cutting their skin because it's folding over. But it's bad. So try to get ahead of it. And that way you're not worrying about, any compartment syndromes or anything like that from that squeezing on it.
I actually heard from a friend, there's no medical basis on this, just my friend's observations, and she's erratic sometimes. She actually got a ring stuck, and Windex was actually is one of the preferred chemical or like solutions to help get jewelry off. So fun facts for y'all.
I mean, it makes sense. That's what one of the things I'll use if I'm doing like my motorcycle tires. I'll spray Windex around the rim to help them slip over the rim and do all that. So it makes sense. Or if you didn't know, again, we're getting kind of off track here, but the string method, if you've ever seen the string method where you wrap the string and that is I've seen that work very well before. It's a good method too.
But if they're burned so significantly they're swelling, those methods are useless. There's no slipping it off at that point.
Yeah, and probably don't spray Windex on their full thickness burn.
You're fine.
Here's a little ammonia for you. It's good. Yeah.
Disinfectant.
We're cleaning that burn.
Yeah.
That would probably hurt so bad. I can't imagine. Inhalation burns, we talked about a little bit already. So this is usually going to be, a lot of the time this is somebody in an enclosed space. And so, the temperature of the whole space goes up and they're breathing that in. So that's mostly where we're going to see those, but it could be all sorts of things, right? It could be for whatever reason they breathed in that superheated air.
I did have a call like this once. Guy's house lit on fire. It was kind of a older house. It seemed like no central air. He had a bunch of heating, like little buddy heaters going on. Ended up catching on fire, and he had just smoke inhalation. So he was crotchety too, unrelated. But yeah, he was one that was fine in the beginning. He's very concerned about his cat. But then as we progressed, he started getting more hoarse. And then the SpO2 was maintaining. His CO was below severe numbers. So oxygen, for the most part, for our treatment acutely was working. But yeah, he started getting raspy and just you could hear the changes going on. There's no physical burn signs on the face or in the mouth, but it is that inhalation, that super hot air that he was breathing in. It's still going to have a lingering effect. Just because there's nothing in the first 3 minutes to 5 minutes that's affecting them does not mean it won't progress.
Did you guys do any humidified oxygen for that guy?
Yeah, by the time he started getting raspy, we were like less than a minute out from the trauma center.
Okay.
Because at that point, I just had him on an arm rebreather, and he was accommodating that really well, and his sats were bouncing nicely upward. But it was one of those like, I should try and cool that off, and then it was like, well, we're here, so I'll tell the doctor to do that, and then they'll ignore that and do their own thing because they're doctors.
And that's something you can do for these patients is, if you have a nebulizer, you can put a little saline in there and then that will kind of nebulize in, almost like a little humidifier essentially. And it will help with those, if you have like a minor burn, that doesn't need airway management, it can help soothe it and help it be a little more comfortable. We already kind of talked about, some stuff that we're assessing for, right? Like the stridor, the hoarse voice, the singed facial hairs and all that kind of stuff. So, that's what we're going to see for inhalation burns. And just think about beyond just the burn, like what did they inhale, right? So we talked about CO already. Make sure that you're looking for that. And if you're listening to this, I would imagine you already know this, but SpO2 being high does not mean there's no CO, and it could actually be the exact opposite. So our red blood cells, our erythrocytes have a higher affinity for CO than O2. And so if it can pick out O2 or CO, it's going to grab that O2. It's going to grab that CO. And so SpO2 is completely unreliable in these patients.
Right. Anybody with a chemistry background kind of already knows this, but nature is inherently kind of lazy, and it takes the path of least resistance, and that's why CO has that higher affinity. There's one oxygen as opposed to the O2 that we normally breathe.
So when I'm lazy, I can just say it's just nature.
Sorry, it's just my nature. Sorry, it's nature in general.
Yeah, it's not even my nature. It's just nature.
Yeah.
Period.
Yeah. Period.
I like it. Okay, cool. I will definitely use that down the line for sure.
I want to know how it goes.
I'll let you know.
Yeah.
I'll let you know.
Beautiful.
Yeah. Be thinking about, what gases that patient was breathing in, right? So it could be CO, hydrogen cyanide's another one that we need to be aware of. So look for, especially in those enclosed spaces, like look at the overall view of the patient. So ask about headaches. Are they altered? Those kind of things. Because unless they're really far down the hypovolemia shock path, they're probably not going to be altered from a burn. So what else is going on that caused them to be altered? We need to be thinking about that.
And then another consideration is like if it's a house fire, for example, how old is the house? Because the materials they used usually like through the 70s were more synthetic and they had a lot of problems with burning, like asbestos and things like that.
Yeah.
This would be a good having a firefighter here to tell us those things.
Yeah, for sure. And just how the burns work for, old houses tend to burn much more slowly because of just how they were built and everything.
Better material.
Yeah, maybe not better, but denser for sure.
I'm thinking like early 1900s, like when it's all hard wood. And,
old growth wood and all that stuff. So not really going to affect what they're going to breathe in, but now there's just more chemicals than there was back then for insulation and stuff. So a lot of it now is just, just nasty chemicals that we're going to have people inhaling in those burns. So, make sure that you are aware of that and looking for that. Management of inhalation burns, like we talked about before, ALS is probably going to be really important here, or just quick transport to the hospital, somewhere where they can have definitive airway care.
Right,
is really important.
Quickly.
And then really thinking about what gases have they possibly inhaled and what are we going to do about that? Oxygen's really good for these two.
We don't have a whole lot of options outside of that one. No. So depending on where you live.
Yeah, oxygen, maybe some humidified oxygen and call it good. Chemical burns are another one that we're going to see. And so there's a wide range of chemicals that can burn patients, acids and bases and all sorts of stuff. So
burn differently.
Yeah. So this one's hard, I feel like, to be really specific about. Just if you suspect a chemical burn, try to find out what it is, right? And this is where having your resources is really important. So I know here ambulances are required to have the ERG, the Emergency Response Guidebook. And so that's that orange book that should have listed out the different chemicals. So
the placards too.
Yeah, and it will list out what all the placards mean. So hopefully you can maybe look there and find it. If it's an industrial thing, look for the MSDS sheets. I think it's MSDS, right? Material Safety Data something.
Sheet.
Something like that.
Makes sense.
I know like factories or stuff will have binders with that information. So if you suspect a chemical burn, try to look and find out what chemical it is.
Right.
Especially if you can before you start treatment, because there are chemicals that are activated by water. So you don't want to start trying to irrigate a chemical and then it makes it worse because it's activated by water. Right. Or whatever.
And a lot of major industrial companies will have some sort of EMS team in the building that's trained specifically to what they use. So utilize them as a resource too. They're going to be a great piece of information for you to utilize. If you don't have that, obviously look for the sheets and see what you can figure out. But don't discredit their opinions just because, well, I'm a 911 medic and I know. They're going to know exactly what they're dealing with and exactly how to treat it. Use them to the best of your ability.
Yeah. And kind of the same thing with resources. Think about hazmat. You might need hazmat for this. So if they're telling you like, hey, this isn't safe for you, get hazmat in there so they can come in and do their thing.
Right. And then, just like everything, we don't want to expose ourselves to this either. So make sure you're wearing the proper PPE. Make sure you're taking the time to decon them appropriately. It wasn't so much a chemical burn, but I had a call with a guy out of the prison who he got 2 cans of mace to get him out of his cell, and I didn't think much of it because it was winter, and so he kept screaming. He was in his underwear, and I was putting a blanket on. He's like, I'm hot. I'm like, that makes no sense. It's 14 degrees outside. And then when we're in the back of that moving ambulance, it's like, boy, my eyes really hurt. And then that's when I put 2 and 2 together. When I asked the guard, he's like, oh yeah, 2 cans. It's like, awesome. I wish I would have deconned before I got into this box.
And especially I know the local hospital, like the trauma center here, I have heard of people that didn't decon very well and went in, had that patient in their ambulance. And so they got a real fun naked bath right outside of the naked shower right outside of the hospital by the nursing staff or whoever, their supervisor. They'll just strip you naked right there in the ambulance bay. I think they have little privacy screens, but they're going to hose you down so that you don't continue to bring that. And they might do that to the patient before they bring him in with chemicals too. They might strip them naked and hose them down.
There's like specific decon teams there for that exact situation.
Yeah. So you don't want to be that guy. You don't want to be that guy that has to next time you walk in, like, oh, hey, Chuck. Yeah, no, yeah, doing great. Thank you. You saw all of me.
Yeah.
Cool. How are the kids?
Yeah.
Good. Cool.
I'll check on that mole like you told me.
Yeah, exactly. So yeah, for chemical burns, try to find out what you can if you can, but there's so many. It can be difficult. But general rule of thumb, we want to, if it's like a powdery chemical, we want to brush it off before we do any irrigation, right? So if we can, we're going to brush it off as much as we can, sweep it off the patient. And then typically we're going to irrigate for 15 to 20 minutes if we can. So it's usually that simple. Just take what you got, irrigate it. Most of the time, we're not going to carry that much, that much water or anything.
Or saline, yeah.
Source it from where you can, but go ahead and irrigate it out. Some specifics are going to be for the eyes. And so make sure you irrigate the eyes if there's chemicals in the eyes. This is something where maybe you'll stay on scene because maybe they have like an eye wash station or something like it was The Office, right? I think there was a good one where they're trying to use the eye wash station. Andy's trying to use it and just can't get it, right? Those are real. You'll find those in places that carry chemicals and stuff. And so, you can do that. Another good thing you can do for irrigating eyes is to take a nasal cannula and you can put that over the bridge of the nose and then run water into that. I had at the Air Force Base here, I had a guy get jet fuel into his eyes. And so I have no idea how that happened, but he was not comfortable. And so we just took saline bags and we just held the saline bag. We just ran it wide open and irrigated his eye out. So when you're irrigating eyes, make sure you're not irrigating one eye into the other with a chemical.
Right, inside out always. We don't want to cause that pooling against the bridge of the nose because then you're just making the problem worse. With the cannula, I actually had a student tell me, I don't remember where she heard this from, but she told me, well, you can take the cannula and you can clip it and then get a big syringe and pull a bunch of fluid, and then that cannula will actually fit over the head of that syringe, and then you could just tape that in place, and then they would give it to the patient who could irrigate it themselves if they wanted to.
Yeah, I like that.
Yeah, a little MacGyver.
Yeah, that's what we do. That's what EMS does. We MacGyver things, right?
Figure it out.
So yeah, that's kind of it with chemical burns. Same stuff as always too, right? Like keep them warm, keep them whatever. Remove jewelry, those kind of things. Expect the swelling.
Make sure if you can find out what it was, if it's something that, was it something that became gaseous as well? Because then you're going to have airway involvement, you have breathing involvement. Certain gases are going to kill people a lot faster than others. Like chlorine gas will basically make you choke in your own fluids and drown. So just for your own safety too, get hazmat involved if you're worried about it, and just be smart about it.
You ever been on a chlorine gas patient?
No, I've just heard the horror stories.
Really? I'm pretty sure I went on a call once for an old lady that was mixing chemicals in her toilet to clean with, and thankfully it was really mild. She had like a headache or something, and like we never went into the bathroom again. Thankfully, pretty sure she made chlorine gas. After we found out what chemicals she was mixing, we looked it up, and Google said that will make chlorine gas, and so we took her to the hospital. But I just thought it was funny that none of the firemen connected the dots in their head. It was like afterwards we were like, what did she say she put in there? Oh, she was mixing like ammonia and something else. Oh, ooh, let's look that. Oh, maybe chlorine gas. Thankfully she got out.
That's the moment when you get to the hospital and you're like, well, that could have sucked.
Yeah, that could have been way worse. Thankfully it was like really minimal.
Yeah.
So yeah. If you can, maybe collect that chemical and dispose of it properly if possible. That's why like an eye wash station is nice. It's going to be disposed properly, but you don't want to make it worse for other people. So be aware of that as well.
All right.
Electrical burns. How about you tell us about electrical burns?
Yeah. So electrical burns, it really depends on what the source of electricity was, So per my electrician friends, it's not the volts that'll kill you, it's the amps. But high or low voltage is going to make a difference, right? So low voltage is going to be, yes, it can disperse through the body, but it's not as transferable as high voltage. High voltage typically, like when I think of high voltage, I think of like there's almost like an entry and an exit wound that's associated with it, because you got to remember that the electricity is going to run that pathway, right? And that's why, you don't want to touch two wires at the same time because then that's going to run electricity through your heart. But these can get pretty gnarly. They can get pretty gross. It also, another thing to consider with like how hot, for lack of a better term, that line was, is that we have a natural reaction to electricity. If anyone's ever played with a TENS unit before, and it makes like your hands cramp up or wherever you put it, right? If it's something where they're touching metal or something that transfers that electricity through, they might latch on, and not because they're trying to, because it's a natural thing. My wife actually had a call like this. We were just talking about it. There's two gentlemen in this exact situation. They were with a forklift and they had a metal pipe leaning against it, and they're like fixing a fence or something, and that pipe caught the power line. One guy, which was my wife's patient, he got blown backwards off of it. He ended up having some pretty severe burns to his hands and believe up his arms. The other guy, he latched on and he got stuck, and he, at that point, basically fried himself with super altered burns. He had the entry and exit wounds, I found out. They can get pretty gnarly, and it's not necessarily the patient's fault if they get stuck in this situation.
Yeah, it's important to remember, like you were saying, that we're not insulators, we're conductors.
Right.
And so we're going to conduct that electricity through us. And that's why you might have those entrance and exit wounds. If you touch something and then your foot is grounding you, it might go from your hand through your foot. And so we need to be really thorough about assessing electrical burns, because there might be gnarly burns. They can be gnarly looking burns for sure.
Yeah, they get gross looking. If you want to look up some gross pictures on the Google machine, that's one.
Yeah.
Yeah, and then I just saw one there. Oh, because of how they transfer, because we're conductors, it's not so much, you'll have superficial involvement. You'll have likely second degree, depending on the voltage. But think about the deep tissue involvement. There's going to be burns that we can't really do a whole lot about. We just got to get them going to the right spot. But I think a bigger concern is that because we are such an electrically based organism, just between our brain and our cardiac activity, things like cardiac arrest are a high likelihood as well associated with the burn on top of it.
Yeah, if you think about the function of a defibrillator is to stop the heart, and now we're defibrillating people because they're getting electrical shock.
Right.
That's could be the same thing, depending on where that electricity hits, can send somebody into, and by where I mean hits the heart in a certain point of the cardiac cycle.
Right.
It can cause somebody to go into VTAC, VFib, cardiac arrest, whatever. The good news is that generally those patients, if they can be managed quickly, are going to do okay. They're going to have a good recovery.
You can actually get into defib pretty quick on these folks too. Especially if it's a witness thing, obviously you're going to be really fast about it. But once you find out the story and you check rhythms, you might be pretty quick into shocking. So don't be shocked if you find that out. If you show up, there's you have cardiac arrest. What happened? Some sort of electrical involvement, and you look at and you put your AED on at the basic scope. Don't be surprised if it says shock first go around.
Yeah,
it would not be surprising.
Yeah, and hopefully it does, because they. Usually, 70-year-old person goes down in cardiac arrest. Their heart is old and tired and abused. A 22-year-old construction worker who's in good shape gets shocked. There was nothing beforehand that caused him to go there. So they should respond back to normal a little bit easier than somebody with cardiac issues or whatever caused them to go into cardiac arrest.
Right. No pre-existing conditions fighting against you the whole time.
Yeah. Yeah. You're not, that was just, you fell off the cliff. You didn't roll down a hill to get to there. You just fell down. You can go back up a little more easily.
Right. Yeah. And then that kind of transfers us into tasers. So tasers can cause some burns. Have you ever pulled out taser barbs? I've never had the opportunity to.
It's not anything special.
I wish it was.
Just real quick and pull them out. Tasers, generally not too big of a deal, depending on where the taser actually lands. If it lands in the spinal column or something, or you can have some significant injuries. I know that there has been reports of cardiac arrest just because of where they were tased and stuff, but very uncommon.
Same with taser-induced seizures. I was actually just looking this up the other day.
Something that you might see out there. Usually I haven't really seen burns from tasers. I've seen the little, the soft tissue injury from the taser probe, but I haven't seen any burns before. So, but I'm sure it can't, right? It's electricity. So especially depending if you maybe have them close together and they arc between each other, you can have some burns there.
It might also depend on the taser, right? If it's one of those like over the counter tasers where it just shocks, right? Like I would expect to see way more superficial burns from that guy.
Yeah, for sure. That makes a lot more sense than like the police style taser that has the probes that are far apart.
Right, the cross barbs there.
Yeah, no, it's not that fun to pull them out. It's pretty basic.
That's disappointing to hear.
Nothing too big. Radiation burns are going to be another type. There's different types of radiation, alpha, beta rays, gamma rays, that kind of stuff that can cause have different effects, right? Like alpha rays are like the sun, and so those are going to be pretty basic. If you're exposed to alpha rays for a long time, you can have those surface burns and all that.
Right.
Whereas if you start to get into higher levels of radiation, then it's going to be deeper and faster and can cause much worse burns. If you're going to go walk around Chernobyl, it's going to be different than standing in the sun.
My sister, I forgot all about this. She bought a new microwave when she moved into her house, new to her microwave, I'll say. And so she was making something and she opened the door and she reached in and she's like, that's still spinning. And her hand was in the microwave, and so she ended up having a little bit of like radiation burning on it, like sunburned herself in a microwave. Special cases for special people, you know.
Yeah, I feel like if the lights are on and it's still spinning, I'm probably not going to put my hand in there.
Yeah, well, when you're really hungry, choices are tough. You got to make them.
That's fair. That is fair, right? Like, yeah. Can I wait? No, I'm hungry. I need my chimichangas.
Yeah, what's a sunburn for this microwave burrito? You know, some things are worth it.
I hear, man, for sure. Yeah, when we're talking about radiation burns, sunburns are probably. I don't think most people are ever going to see a real radiation burn in their career.
Right.
I feel like you'd probably be specialized working somewhere that radiation is around before this would happen. Unless it's a zombie apocalypse or something and nuclear war or something, then we're going to see it.
And wherever you work that's going to have that high radiation exposure nowadays, they're going to have to prep you on that as well. They're not just going to throw you in blind. It's not like it's the 1960s anymore.
Good luck.
Yeah.
Figure it out.
Heat up your food on a nuclear vent. That's what my uncle did. Yeah, it's crazy.
Nice. So make sure, for testing stuff, right? Make sure you know alpha, beta, gamma rays and kind of how that operates. Alpha is like the sun. It's more minor and it gets worse, but like we were saying, realistically, not super concerning.
Right.
People can, if they have like radioactive material on them or something, they can be contaminated essentially, and they can continue to burn or burn other people or cause issues there. Again, probably not going to see anything like that. Going to be very, very rare, unless it's, Homer Simpson walking away with the intro to The Simpsons. He has like the glowing bar that like gets stuck in his collar, right? Like that kind of thing isn't going to happen.
Right.
So probably pretty safe with that unless you are knowing you're going to have that exposure beforehand. Right. Probably not what we're going to go on.
And most people have actually been exposed to gamma radiation without even thinking about it. That's what X-rays are. It's just gamma radiation, right? So that goes through everything. Beta waves you can block with the right equipment. Gamma rays, there's no real stopping it unless you're going to use things like a lead-lined apron.
Yeah, which is exactly why X-ray techs and stuff will wear those. Or if you're at the dentist, they'll put a lead apron on you if they're just doing scanning your teeth or whatever, and why you're supposed to limit the amount of X-ray you have done, at least over a period of time, to limit your exposure to those.
I always think it's funny when they're like, X-rays are harmless, and then they go and run and hide behind a lead-lined shield. It's like, harmless.
Yeah, as they're in the bomb shelter, pressing the button.
Yeah. No, yeah, you're good.
Am I really?
Yeah.
Am I now?
It's all in the mind,
Yeah, I think for treatment, it's not going to really be any different for radiation burns than anything else.
Maybe deconning, but that will be fairly specific to whatever it's going to be. We didn't really touch on it, but we did touch on it of like using dry dressings, right? Really important.
So overall treatment kind of stuff,
Yeah, so dry dressings for obviously temperature management. If anyone's ever had like a turf burn before, they know what it feels like to have clothes stuck to that. And so that the fear of like, I don't want to stick that gauze. That's why a lot of people want to go that wet route instead of the dry. The hospital is more than likely going to debride the burn anyway. They're going to have to clean it out. So they're going to take that off, and they're going to take that off probably with saline, but it's going to be in a very controlled environment. Pro tips, when people get exposed to like flash fire, their eyelids are going to get it. So if you can put dry gauze on their eyelids, and if they burn their hands, make sure you put gauze in between their fingers. Otherwise, their fingers are going to stick together, and that's a whole other nightmare. But yeah, just generally, it's fairly straightforward as far as treatment goes.
Yeah. I mean, yeah, get that good recognition, go to the right place, keep them warm, dry dressings, like burn dressings are sterile dressings, and we don't want to put, something that's not going to be sterile up against that just direct pathway to the inside of a patient's body, because their skin is burned away. There's no more protection. So we don't want to do that. We need to make sure it's a sterile dressing that we're going to lay on, dry sterile dressing, and just really watch that airway, manage that airway, and go to the hospital. Yeah, there's just not a lot we can do for these patients, at least at the BLS level. Right. If you're going, like we said before, if you're going to the ALS level, know your protocols as far as fluid management. If I don't know that it's as common for ground medics, but like flight medics will do Parkland burn formula. I know, pro tip, if you're listening to this and you have aspirations of being a flight medic, I think every flight medic I've talked to, Parkland burn formula has been part of their interview process, that they've had to on the fly be given patients and do that in their interview process. So super common there. And then maybe pain management at the ALS level, or maybe even ILS if you have that in your ILS scope.
Right. And you could also remember medical control is an option. I'm blanking the name of the procedure. I think I have them, but I think it's wrong. But like if they, if we're worried about compartment syndrome, say we're far enough out where we are not within 15 minutes, 20 minutes of a hospital, we're pushing an hour, 2 hour, call medical control, because if that swelling gets so severe, compartment syndrome can develop, and they may actually advise you to cut skin.
I believe it's an escharotomy.
Yeah. I was thinking of episiotomy, but I think that's pregnancy
related. That is when they, we're not going to talk about that one yet. Yeah. That's a whole different procedure. Yeah. Don't try to Google that one and watch it.
Or do, but don't.
Escharotomy, I believe, is where, for the compartment syndrome. So as it's swelling, there's only so much it can swell. So you make a relief cut, essentially, to allow it to swell more.
Right. Yeah. I mean, that's just out of our scope, obviously, but if situations are pressing enough, they're definitely going to do that. Another thing is trust your gut, especially if you're worried about airway stuff. A piece of advice I got early in my medic career that kind of just changed how I view a lot of things is, if you're thinking about it, you should probably do it, because we would rather over triage and be a little wrong, as long as we're not obviously dosing medications and things for the wrong reasons, but we'd rather over triage. If you're like, I don't know, they're talking just fine, maybe a little hoarse, I'm not going to put them on oxygen. What's it going to hurt if you do?
Yeah.
Right. Over triage, trust your gut. If you're thinking about it, you should probably just do it.
Yeah. There's a reason you're thinking about it. So follow that path. Cool. Right on.
That's all I got for you.
Cool. That's all we got for you. Thanks for listening. Thanks for watching. Check them out. We got lots of other episodes to check out. Hit subscribe if you're on YouTube. We love comments and all that stuff too. If you're on Apple Podcasts, Spotify, or whatever, give us a rating, and we will see you guys next time. The Wade finger guns.
Classic.